Hi, my name is Vanessa Downey. I'm a second year nursing student in the Friday Sim Lab from 10 to 12. I did my presentation on congestive heart failure and blood transfusions. To start, congestive heart failure or chronic heart failure is characterized by the progressive worsening of ventricular functioning and chronic neurohormonal activation that results in ventricular remodeling. Through this process, the size, shape, and mechanical performance of the ventricle is dramatically changed. The onset of heart failure may be acute, as after an MI, when direct damage to the heart's ability to contract has occurred, or chronic, as with hypertension, when the ventricles consistently pump against an increased pressure. To start, the first question is identify which subjective questions would elicit signs and symptoms of this condition. So you want to ask or inquire to your patient about dyspnea. So you want to ask, are you experiencing any shortness of breath? The onset of this, so does the shortness of breath come unexpectedly? And the duration, does it come and go? Or what kinds of activities, if any at all, bring this on? You also want to inquire about orthopnea, which is the need to assume the upright position to breathe. So you want to ask, how many pillows do you use, if any, when sleeping or lying down? You want to inquire about cough, so you want to ask the patient, do you have a cough, and are you coughing up any secretions? And if so, are they frothy pink or white with sputum? You also want to inquire to patients with congestive heart failure about fatigue. As fatigue is a result of decreased cardiac output, you want to ask, are you easily fatigued? And the onset of this fatigue, and what time of day do you feel most fatigued, if there's any specific time. So is it all day? Is it more in the morning, or is it in the evening? You want to inquire about cyanosis or pallor. So you want to ask the patient, have they noted any ashen skin, or have they noticed their skin to turn blue on their lips, fingers, or toes? You want to inquire to the patient about edema. So you want to ask if they have noted any swelling in their feet or legs. You also want to inquire about nocturia. You want to ask the patient, do you awaken at night with a sudden urge to urinate? You also, in your subjective questions, you want to ask about cardiac histories. So do you have a family, you want to ask the patient if they have a family history of hypertension, elevated cholesterol or triglycerides, if they have a heart murmur, if they have a history of congenital heart disease, obesity, coronary artery disease. And you also want to ask the patient if they have a history of a previous myocardial infarction. You also want to inquire to the patient about personal habits that could elicit cardiac risk factors. You want to ask about their nutrition habits, if smoking habits, alcohol use, exercise habits, what types of medications that they're using or that they've been on, and any stress-related issues. So the next question in congestive heart failure is identify what signs and symptoms may be discovered during inspection. So patients with CHF or congestive heart failure may present with findings such as visible swelling in periphery, dilated pupils. Their skin upon inspection may be pale, gray, or cyanotic. You may note jugular vein distension. And you want to inspect their anterior chest for a heave or a lift, which indicates forceful thrusting against the ventricles. You also want to note any abdominal swelling or distension, which could be caused by ascites. And you also want to note if your patient is visibly fatigued or in a visible state of discomfort. Next, you want to identify signs and symptoms that may be discovered during palpation. Signs and symptoms that may be discovered during palpations in patients with CHF include weak pulse, dependent pitying edema in sacrum and legs, enlarged spleen or liver, and distension in the abdominal region, which causes discomfort upon palpation. Next, identify what signs and symptoms may be discovered during percussion. So in cardiac assessments or in patients with chronic heart failure, percussion is normally not used in this assessment with patients with suspected heart failure. Percussion, when it is used, is supposed to outline the cardiac borders of the heart, but this has been replaced with chest radiographic images or an echocardiogram. But a suggestion, if percussion were to be used or is to be incorporated in the assessment, you could use percussion to over the abdomen to inspect or confirm ascites, as fluid buildup will produce a dull sound. And lastly, identify what signs and symptoms may be discovered during auscultation. So upon auscultation, crackles could be located at the bases of the lungs, rhonchi, wheezes may be present, tachypnea, tachycardia, there may be a presence of S3 and S4 heart sounds, murmurs, gallop, and a decreased blood pressure, which stimulates the sympathetic nervous system, which acts on the heart to increase the rate and increase the force of contraction. I'm going to be talking about blood transfusions. Blood transfusion is the intravenous administration of whole blood cells or a component of blood such as plasma, packed red blood cells, or platelets. Blood transfusions are indicated in patients who endure severe trauma, surgery, or hemorrhage to increase circulating blood volume, to maintain hemoglobin levels by infusing RBCs in anemic patients, and to provide cellular components as replacement therapy. Blood types and checks before administration. Blood types are arranged in the ABO system, which includes A, B, O, and AB blood types. Blood type is determined if they have the presence or absence of A and B RBC antigens. People with A antigens, people with B antigens, or people with no antigens belong to the ABO or AB blood types. Rhesus or Rh factor, which is the second important consideration in blood typing. The Rh factor is an antigenic substance in the erythrocytes. A person with this factor is Rh positive, and a person without this factor is Rh negative. Before administration, blood must be matched prior to giving it to the patient. The primary healthcare provider must obtain consent from the patient for the transfusion, and the nurse must verify this consent. Consider patients that may have cultural or religious backgrounds that abstain from blood transfusions. Inquire if the patient has had a previous blood transfusion before, and explain the procedure and ensure they understand the transfusion. Inform the patient to report any side effects, chills, dizziness, or fever. Obtain baseline vitals before the infusion. Ensure the patient is properly identified. 8 rites should and must be completed, and 2 registered nurses must check and ensure the transfusion is safe for the patient and no discrepancies are present. Equipment and solutions. If the patient has a venous line in place, assess the site before initiating the transfusion, and the nurse should use an 18 to 22 gauge needle for the infusion. Blood administration tubing is the Y tubing infusion set and is also used in combination with a 70 to 260 micron filter needle. A 16 to 18 gauge needle is required when rapid infusion is necessary. And when priming blood administration tubing, 0.9% normal saline must be used to prevent hemolysis or breakdown of RBCs. The rate of infusion is usually indicated by the physician's order, but in general, the initiation of the transfusion begins slowly. The infusion must begin within 30 minutes of accessing the blood component and stopped after 4 hours or after 2 units. Transfusions are given slowly and monitored closely to allow for the early detection of transfusion reactions. The nurse needs to maintain the infusion rate, monitor for side effects, assess vitals, and promptly record all findings. The nurse should observe for hives, fever, dyspnea, cough, back or infusion site pain, and note if the patient complains of any unusual feelings. Transfusion reaction and interventions. If a blood reaction is suspected, stop the infusion immediately. There are non-infectious complications such as an allergic reaction, which could be mild to severe, hemolytic transfusion reactions, and ABO transfusion reactions. A second category of transfusion reactions include infectious complications, which include diseases transmitted by infected blood donors who are asymptomatic. Finally, transfusion reactions can occur due to circulatory overload, which is when the patient receives a large volume of whole or plaqued RBCs, an RBC transfusion for massive hemorrhagic shock, or when a patient with normal blood volume receives blood. Interventions of the transfusion include maintaining the patient's physiological stability by keeping the intravenous line open by hanging 0.9% normal saline. Do not turn off the blood and simply turn on the normal saline, as this would cause the remaining blood in the Y tubing to infuse into the patient, and we want to stop that blood from infusing. Notify the primary healthcare provider, remain with the patient, and assess vitals as often as every 5 minutes. Prepare to administer emergency drugs for example, as antihistamines, vasopressors, fluids, and steroids as per physician's orders. Prepare to perform cardiopulmonary resuscitation, obtain a urine specimen, and send it to the lab to determine the presence of hemoglobin as a result of RBC hemolysis. Save the blood container, tubing, attach labels, and transfusion record, and return them to the laboratory. And that's it for blood transfusions and chronic heart failure. Thank you.